Hey, welcome to Osteo Boston. My name is Shelley Gladstein, and I'm the host of Osteo Boston, and I'm excited to have you be here tonight. Our community is a community of solution seekers for better bone health. And to all of you that are our community, I want to say welcome, and I'm so glad you're here. To our YouTube audience, I want to thank you for listening. And if you like what you see, give us a thumbs up. If you want this kind of content on a normal basis, go ahead and subscribe to our channel. So I'm pretty excited about tonight's speaker. I want to tell you a little bit about Dr. Stephanie Osiecki. And so let me go ahead and do that. We're going to have Dr. Stephanie Osiecki tonight speak on the subject of menopausal hormone therapy and bone health. I'd like to just share a little bit about her. She graduated from the University of Vermont College of Medicine, where she obtained her MD. She then went on to Brown University and has a clinical specialty in internal medicine. She's been a highly rated doctor with over 25 years of experience caring for patients. She's also the former co-owner of an award-winning independent primary care practice with a focus on women's health, preventative health, and medically complex patients. She is currently expanding her reach and others' access to care through her association with Midi Health, a telehealth platform serving women in midlife. Osteo Boston has eagerly anticipated your talk tonight, Stephanie, on Dr. Osiecki,
You can call me Stephanie.
hormone therapy and bone health. So we are thrilled to have you, and let me add you to the screen. Thank you so much for joining us.
My pleasure. So thank you for inviting me, Shelley. Anyone who knows me at this point in my life can tell you that I love to talk about bone health. So I'm really excited to be here and to talk with all of you about bone health, one of my favorite subjects. So I'm going to share my screen and pull up my slides and see if we can make this work. It should, oh no. Okay,
Here it is.
here it is, but where's this, where is the buttons are covered
I
here.
think on the bottom left corner.
I think,
I think when you click those 4 squares, little teeny squares at the very corner.
we want slideshow. There we go.
Oh, okay. Oh, okay.
So, now, sorry, maybe Shelley, maybe it was a mistake for me to say I would do this. Because now you guys can see my screen. Now everyone's picture is
No,
front of the content. Okay, okay.
no, you're perfect.
Okay, so I'm going to talk tonight about hormone replacement therapy and bone health. And let's see if I can, I'm so sorry. Oh, that's going to be tough. Okay. So actually, Shelley, thank you so much for that great introduction. I don't think I need to go through who I am again. I'm Dr. Stephanie Osiecki, and I am currently the medical director of quality and a clinical leader at Midi Health, which is a telehealth platform for women. So Midi was really founded by some women who were in their 50s or early 60s who were struggling to obtain care for their menopausal symptoms. And one of the other founders is a classmate of mine from medical school whose real passion was providing care for symptom relief for cancer survivors. And so these groups came together to form Midi. And our original focus is really menopause, perimenopause, and the symptoms from cancer survivorship that go along with that. And we're expanding our care into other areas. And because bone health is part of menopause, perimenopause, that's always been part of our program. Let's see if I can make the slide change. All right. We have a really, really great team of physicians and mostly nurse practitioners who are really passionate about menopause care, women's health, and are deeply trained in hormone therapy. We're open in 50 states. We take many major insurances. Talking with Shelley last night, we don't take Medicare yet, so I'm sorry to say that, but I hope that we will. Just a disclaimer, the information in this webinar is just for educational purposes, is not meant to be individualized medical advice. So topics tonight, I'm going to talk about menopause a little bit because when we talk about hormone therapy, they go hand in hand. And then I'm going to talk about estrogen and bone health. And then last night, speaking with Shelley, she told me that y'all were really interested in the risks and potential benefits of hormone therapy for women who are a little bit older. So an hour ago, I added a section about the risks of hormone therapy because I think that will interest this group. So I will dive into that as well. So this may be a refresher for everyone in the room, but menopause is the moment when a woman reaches 12 months from her last menstrual period. So at this time, so this is 12 months after the final menstrual period, estrogen and progesterone levels drop, and these hormonal shifts can cause many physical and emotional symptoms. When does menopause start? The average age of menopause is about 51 and a half. But many women experience menopause between 40 and 45, and some women have premature menopause before the age of 40. The average age is 51.5, but we still see people maybe a little bit past 55 who are still having periods. What happens to estrogen levels during menopause? So this little chart shows the estrogen level. Can you guys see my arrow? Shelley, do you see it?
Yes.
Good, because then I can use it to point. So this shows generally estrogen levels until puberty, and we see in puberty we've got some real chaotic ups and downs here until things settle out at a nice high level until we reach menopause, and the level tends to decline. But again, perimenopause can be a very chaotic period for hormone levels with lots of fluctuating symptoms, and then finally postmenopausally those estrogen levels are back down here where they were before puberty. Menopausal symptoms, probably don't have to explain all this to you folks, but bone loss is a very important symptom of menopause, or very important consequence of menopause. But people experience all of these: hot flashes, night sweats, trouble sleeping, feeling forgetful, mood changes, irritability, changes in libido, genitourinary syndrome of menopause, vaginal drying, which includes loss of estrogen to those tissues. So people experience vaginal dryness, painful intercourse, frequent UTIs, stress incontinence. We also are starting to recognize more and more around menopause that women can present with diffuse joint pain, where they just feel sort of achy all over. Maybe they've seen a couple of specialists, nobody can find anything wrong. Turns out every tissue in the body actually has estrogen receptors, and the joints are no exception. So this syndrome of menopause also is sometimes helped with hormone therapy. So when women have menopausal symptoms, we have lots of options. So starting with pharmacological options, number one here, systemic hormone therapy, which is what we're going to talk about mainly tonight. But treatment of genitourinary syndrome of menopause is very, very important. Many of the symptoms of menopause decrease 10 years out, but vaginal atrophy continues. And so it's very important to treat with local or vaginal estrogen to keep that tissue healthy and help prevent UTIs. There are many prescription medications that can help with the symptoms of hot flashes, night sweats, and many of the things I just mentioned. Some of them are FDA approved, and then there's a variety of medications that we use off-label also to try to counter those symptoms when hormone therapy is not the right choice. There are many non-pharmacological options: supplements and botanicals, medications or botanicals that you've probably heard of, like black cohosh, Siberian rhubarb, maca. There are many botanicals that have a good track record of being helpful for these symptoms. And then, of course, lifestyle is very important. I think y'all probably know a lot about healthy lifestyle. So hormone therapy is the most effective treatment for quick relief of menopausal symptoms. So hormone therapy is estrogen plus or minus progesterone. So estrogen is really the hormone that mainly relieves the symptoms of menopause and helps with bone health. It was found we started using estrogen in the 50s to treat menopausal symptoms, and women were treated with estrogen alone for many years. And it was found that there was an increased risk of uterine cancer when estrogen was used alone. So estrogen tends to build up the lining of the uterus, and progesterone keeps it thin and balanced. So for women who have a uterus, many women have had a hysterectomy, but women who have a uterus, when they use hormone therapy, they use a progestin along with it. Women who've had a hysterectomy can use estrogen alone. And hormone therapy it's actually really fun to treat people with this because people feel so much better so quickly. Hot flashes and night sweats clear up. Genitourinary syndrome clears up. People sleep better, feel better. For people who start hormone therapy close to menopause, there's evidence that we do see a lower risk of heart disease. We see a decreased risk of death from all causes, and we see, very importantly, improved bone health. So what is hormone replacement therapy? So as I said, it's estrogen plus a progestin. So estrogen can be taken as a pill. It can also be provided as a transdermal patch, spray, or gel. There's also a vaginal ring that delivers enough estrogen to be received systemically. Oral estrogen in the pill form is associated with increased clotting risk, but transdermal estrogen, because estrogen is able to just enter the bloodstream without passing through the liver, transdermal estrogen is not associated with increased clotting risk. So we generally prefer, whenever possible, a transdermal formulation like a patch, spray, or gel. So who is hormone therapy right for? It's appropriate for many patients, and there are people for whom its appropriateness is very obvious, and there's many patients for whom a very careful risk-benefit analysis or conversation is relevant, but it is appropriate for most patients. There are people that it's not recommended for. So hormone therapy generally isn't right for women who have hormone-sensitive breast cancer, for women who've had a stroke, certain types of blood clots, coronary artery disease, advanced liver disease, or current vaginal bleeding, then hormone therapy is not the right choice. And we do have, for menopausal symptoms and for osteoporosis and osteopenia, lots of non-hormonal options. So it's very fun to treat patients with menopausal symptoms because when we have this whole armamentarium available, hormonal, non-hormonal, botanical, we find that 91% of our patients feel better by their next visit usually. Questions usually arise about how long you can take hormone therapy. For a very long time. You all probably have heard this. It was recommended after, I'm going to talk a lot about the Women's Health Initiative, which is a big study about hormone therapy that was very scary. But for a long time, it was recommended that women use the lowest dose of hormones for the shortest period of time that in order to relieve their symptoms. But looking at that data 20 or more years later, plus other studies, we find that it no longer is necessary to have age be a defined stopping point. There isn't an actual cutoff for every person. It really depends on their personal health history and their values and priorities. So we use a shared decision-making model. We look at the person's current health history, their screenings, any changes in their history, to make a decision about how long to continue hormone therapy. But there's no longer any, okay, it's your 60th birthday, you have to stop this now. Many patients do stop their hormone therapy. People use it for some years and wonder if they still need it. Many patients will stop it, and many of them feel fine without it. Some people have symptoms recur and want to continue, and that's fine. I support that. So let's talk about your bones at midlife and menopause. So when estrogen levels drop during menopause, bone density declines, and on average, women lose about up to 10% of their bone mass during the first 5 years of menopause. So estrogen helps to maintain bone strength and density by preserving healthy bone and promoting new bone formation. So I wanted to show you some of the studies that show that hormone therapy increases bone density. So I thought about doing the Women's Health Initiative first, but I kind of wanted to begin with this. But much of the Women's Health Initiative was a large study I mentioned that was stopped because of concerns in 2001. So most of what we know about hormone therapy, the research was done before 2001. After 2001, very little research has been done. So we have great studies from quite a while ago that actually show that hormone therapy increases bone density. So I'm going to walk you through the PEPI trial, the HOPE trial, and the ultra low dose transdermal estrogen trial. So here's the PEPI trial. We've got some complicated graphs here, but I know y'all are very sophisticated. So the PEPI trial was postmenopausal estrogen and progestin intervention, 1996, 875 women over 3 years. So on the y-axis, we have the change from baseline in percentage, and on the x-axis, the years. So, and then we've got a lot of different treatment strategies here, but all of these colorful lines up here are the patients who are either on estrogen alone, estrogen and medroxyprogesterone, or the medroxyprogesterone might have been cycled. So these groups are all the treated patients, and then this sad green line going down is the placebo group. So what we saw in this study is that all of the women who were treated with hormone therapy, whether it was estrogen with or without progestin, had an increase in bone density in their spine of 3.5% to 4%, while those who were treated with placebo had a decrease of 3.5%. And I'm sure you all understand that they may seem like small changes in percentage, but they translate to large changes in fracture risk and an increase in bone density. You know, if you're on treatment and you come back and you have your bone density done again, and you find that your bone density has increased 3%, that usually feels pretty good. That's a meaningful change. So we see this kind of result at the spine and at the hip. Same thing. The treated patients had a nice increase of 1.5% to 2% after 3 years, and the patients on placebo had bone loss or bone mass loss. So then we have the HOPE trial, 2002, 822 women over 2 years, very similar result. All these colorful lines here are the treatment group, and we see in the patients with estrogen alone, 2% to 3% increase. As patients treated with estrogen and medroxyprogesterone, we see 2% to 3% increase. These are both in the spine, and then a decreased bone density in patients who were on placebo. So the Women's Health Initiative was closed or stopped in 2001. And so one of the next things that happened in terms of estrogen health was an effort to discover what the lowest possible dose of estrogen could be used to support bone health. So this is so instead of trying to figure out how much can we help with more, the focus was seeing that if we can use a very, very low dose and get some effect. So this was 417 women who were randomized to either, this is a very low dose estradiol patch. Generally, women who are on hormone therapy will use 37, 50, 75 micrograms of estradiol as a patch. So this was super low, half of the lowest dose. And yet we still saw a nice increase in bone density at the spine and preservation at the hip, where we saw loss of bone density at the hip in women who were on placebo. So finally, we reached the Women's Health Initiative, which I'm going to come back to more when I talk about risk. But the first 3 studies I showed you were all showed that estrogen will increase bone density as measured by DEXA. But the Women's Health Initiative showed that it also decreased fracture risk. So this is cases per 10,000 women per year. So we see a nice decrease in fracture risk in women on estrogen alone, and an even greater decrease in fracture risk in women who are treated with estrogen and medroxyprogesterone. So we know that estrogen preserves bone, builds bone and decreases fracture risk, but what happens if you're on it and then you stop it? Like other treatments for osteoporosis, after therapy is discontinued, bone loss resumes. And we see a rate that's similar to the rate during menopause. So 1.5% a year, a little less than 1, 0.5. Sorry, I have, this thing is covering this part of the slide. So many women choose to continue hormone therapy indefinitely when bone health is a priority for them. So summing up about estrogen, estrogen increases bone density and decreases fracture risk. It has a robust protective effect to preserve healthy bone. Estrogen is actually FDA approved to prevent osteoporosis in women with osteopenia. So the FDA saw fit to approve estrogen for the treatment of osteopenia. Estrogen can and should be prescribed for women with osteopenia to prevent osteoporosis, even if they're not bothered by other menopause symptoms. In spite of the evidence for its efficacy, it's not FDA approved for the treatment of osteoporosis due to concerns for the risks. Women who have osteoporosis can use hormone therapy even while they're being treated for their osteoporosis with other medications. So hormone therapy versus bisphosphonates, which is stronger? So we see from the studies I showed you that hormone therapy can increase bone density by 3 to 5% over 3 years. Looking at a 3-year period, bisphosphonates increase bone density by more like 4 to 8%. So bisphosphonates are a little bit more powerful. So who should consider hormone therapy for bone health? Patients with osteopenia. Even though it's not FDA approved, I also think that patients with mild early osteoporosis as measured by DEXA are potentially good candidates. So we know the bisphosphonates are stronger. We know that they're going to be a little bit more effective. But women who are looking at treating osteoporosis for 10, 20, 30 years may reasonably consider hormone therapy as initial treatment if they have mild early osteoporosis, because I think you all know that we use the bisphosphonates for 5, 7, maybe a little bit longer. So if you're looking at 30 years of therapy, starting with hormone therapy can extend your choices over those decades. So people who've just tipped into, just crossed over that negative 2.5 line on their DEXA, haven't had a fracture, could I just use hormones instead for a while? I think that's a very reasonable choice. Patients with more established osteoporosis or with a history of fracture, probably better candidates for bisphosphonates or the newer anabolic bone building medications. These patients can still have hormone therapy for other menopause symptoms. We don't see a huge additive effect. You would think like 1 + 1 = 2, but it's more like 1.2. So you don't double the benefit by using 2 therapies when the second one is hormone therapy. I thought I'd talk a little bit about testosterone. So I'm going to talk about testosterone in women because I treat women generally. And we don't have very much data on testosterone in women. Most of the data about testosterone in women is focused on its modest beneficial effect for libido. So what do we know about testosterone in the bones in women? We know that in men, hypogonadism is a well-established cause of osteoporosis. We have seen some small studies that show that lower levels of testosterone are correlated with lower bone density in women. We have some small studies from the 1990s that showed a greater increase in bone density in women treated with hormone therapy that included testosterone and hormone therapy alone. These are studies with like 20, 30 people. Anecdotally, I've seen endocrinologists sometimes add testosterone when other treatments are not working. Patients with very low bone density or fractures that would heal. So testosterone is sometimes used to treat lower libido during menopause. There seems to be an association between lower testosterone levels in women and osteoporosis. It's not standard of care, certainly not alone for osteoporosis, but women who choose testosterone supplementation probably also enjoy a benefit to bone health. So what we want you to know, hormone changes during menopause can increase your risk of osteopenia and osteoporosis. Treatment can prevent and even reverse bone loss. And treatment with hormone therapy needs to be individualized based on a person's health history. and values. So, okay, I just added these because I heard y'all want to talk about risk. So back to the Women's Health Initiative. So I'm gonna go back in time to the late 80s, 1990s. There were many observational studies that showed that women who used hormone therapy had a lower risk of heart disease than women who did not. So there were dozens of observational studies that demonstrated this. An observational study is where we just see women who filled a prescription had less heart attacks, or women who were on hormone therapy had less heart attacks. No control group, no comparison group. So people looked at these studies and said, looks like maybe that would be helpful, but we don't know, is there something different about these women? Maybe they're healthier, maybe they have better lifestyles, maybe they advocate for themselves more, and that's why, you know, they got to hormone therapy. So maybe this group of people who self-select for it is different. Let's do a randomized controlled trial. But I want you to keep in mind that group of healthier women, or possibly healthier women, possibly more health conscious women who seem to have lower risk of heart disease on hormone therapy. So it was decided by the NIH to run a huge trial to see if hormone therapy could prevent heart disease in women. 68,000 women enrolled in a randomized controlled trial. So they were matched for age and habits and lifestyle and weight, and then half were giving hormone therapy and half were not. And they were followed, actually they've been followed for more than 20 years now, but initially the study began. And at about the 3-year mark, there was concern that there was a signal that there was an increased risk of breast cancer in these patients. And this was published in the New York Times, and it was described as a 25% increased risk of breast cancer. So what was not emphasized was that in the treatment group, they were expecting to see about 3 cases of breast cancer per 1,000 women per year. And they were seeing 4 cases of breast cancer per 1,000 women per year at one point during the study. So that was 25%. That was all the newspaper needed to hear. So this data never actually quite reached statistical significance, but it was close. And so you know, there is and still remains concern that there may be a very small increased risk of breast cancer. That is questioned now. But for most women who are contemplating hormone therapy, you know, the real risk is being a woman, where your risk is 1 in 8 in your lifetime. So the possibility that there might be another case per 1,000 women is a risk that most women are willing to weigh when they're considering treatment of their symptoms. So that's about breast cancer risk. So the study was stopped, and then the people who were treated for the first few years of the study continue to be followed. So this is data from about 13 years later. So we see what happened to the patients who were on hormone therapy for 3 or 4 years versus those who were not. So these patients were treated with conjugated equine estrogen, also called Premarin. It is a group of estrogens that is purified from pregnant mare's urine. That's where the name Premarin comes from. So this is an oral estrogen. Oral estrogens are well known to increase clotting risk. So these women were mostly treated with Premarin and medroxyprogesterone, which is a synthetic progesterone. There are many different progestins, and they have different affinities for receptors in the body, like breast tissue. So these women were treated with conjugated equine estrogen and CEE plus medroxyprogesterone. So we'll look over here. So let's go over how does this graph work? So we've got the absolute risk per 10,000 women per year. So this is the actual number. Deep venous thrombosis. There were 5 more cases of deep venous thrombosis per 10,000 women per year in the estrogen arm. So this dotted red line here is where this reaches 1 per 1,000. Because when we look at studies like this, we generally think if we're seeing an effect that's less than 1 per 1,000, it's really hard to know if that's true or clinically impactful. If it's true and we're treating millions of people with this, then it can add up. But you know, if we're seeing maybe 1 more case, or in this case, half a case per 1,000, then we have to look at it a little bit more carefully. So we know oral estrogen increased clotting risk. There's no surprise here that there's more DVTs and pulmonary emboli, clots to the lung in the treatment group. We really don't use oral estrogen now. Anyone who's interested in hormone therapy and is concerned about these risks can certainly use transdermal estrogen, which does not increase clotting risk. So we're going to look over at the rest of this slide. Estrogen alone, we see potentially a little decrease in heart disease, tiny decrease in stroke, a decreased risk of breast cancer in estrogen alone. It was the progesterone that was probably causing this possible increased risk. So decreased risk of breast cancer, colorectal, all cancers, fractures, death from any cause, diabetes, we see decreased risks. When we add the progestin, medroxyprogesterone, we see possibly a little bit more cardiovascular risk and possibly breast cancer, but again, a nice robust effect on fracture. So this was looking at the whole group where the average age was 62. And these women were chosen for this study because they were older and had some cardiovascular risk, because we were really trying to optimize being able to detect a change in heart disease here. So eventually someone got around to looking at this group by age. And what they found, I don't have a slide on. What they found was that women who were under 60 or less than 10 years from menopause had reduced cardiovascular risk. And that women who are over 60 or more than 10 years from their last menstrual period may have some increased cardiovascular risk. There seemed to be a small increased risk of stroke at all ages. And so looking at this group, which I think y'all are sort of interested in, what about patients? So I'm sorry, I'm going to back up a little. So these patients under 60, less than 10 years, there's great agreement now that unless there's something going on like breast cancer or clotting, that these patients are good candidates for hormone therapy. Then we start to feel a little bit more concerned about women who are over 60 or more than 10 years. Guiding agencies like the Menopause Society, the Endocrine Society, tend to use this framework. If you're over 60 or more than 10 years from your final menstrual period, then there's increased risk. So take care, be careful. If we think about that observational study where we thought maybe healthier women had decreased risk, we realize it's not your birthday. Your risk doesn't go up on your 60th birthday. It's really about your baseline cardiovascular risk. So if you're over 60 or more than 10 years from your last menstrual period, I don't think, and at Midi, we don't practice that there's a bright line here where you can no longer have hormone therapy. We want to look at your personal cardiovascular risk and see, if your baseline risk is high, then hormone therapy might be a little bit more risky for you. But if your cardiovascular system is still very healthy, then your risk is more like this group. And so how do we estimate cardiovascular risk? We should estimate it based on your health profile, your risk, not on your exact age or the number of years from your last period. So a couple of ways to do that: ASCVD risk. Maybe you all have seen this before. You can calculate it yourself from the American Heart Association. You put in your age, or your doctor does this, your age, your blood pressure, your cholesterol, whether or not you smoke. And it comes up with a number like your chance of a heart attack or stroke in the next 10 years, it's 2%, 3%, 5, 7. So this is a good way to estimate risk. Another really good way to estimate risk these days is with a coronary artery calcium score. This is a CAT scan of the coronary arteries, which is being used more commonly to see if people are at risk of a heart attack. So we use these indirect measures, measuring blood pressure, measuring cholesterol, using a calculator. But now we can look at the arteries and say, are they full of plaque or not? Because if they're not, then maybe you fit into this category here, where hormone therapy is a reasonable choice. I have this nice table from the American Heart Association Committee on Women's cardiovascular health. So they came up with this model. So thinking about women who aren't in that ideal window, low risk, recent menopause, normal blood pressure, that CVD risk is low risk for breast cancer, they get a nice green light. Intermediate risk for people with some cardiovascular risk factors, ASCVD risk is a little higher. And then high risk, folks who have coronary artery disease, some clotting problems, stroke, breast cancer, their risk is high. But even in the paper where this table was published, even in this group, the American Heart Association, American College of Cardiologists statement is, even for these high-risk patients, an individualized personal risk-benefit conversation and shared decision-making is appropriate. So based on concerns about bone health or symptoms, even some of these patients are hormone therapy is the right choice for them. So that's what I have for you. Just want to mention I work with Midi, and I would love to see you all. If you would like to talk more about this, we have clinicians in 50 states. I'm very sorry to say that we are not accepting Medicare at this time, but we are working on it. And I'm ready for questions.
Okay.
I'm gonna stop
Hold on.
sharing. That was a lot.
Hold on just a second. Let me see. Your screen is gone, but let me just see if I can. I'm sorry, just give me a
Oh,
second.
take your
Ah,
time.
there we go.
Because I know
Okay.
it's a very, very
Okay.
sophisticated, educated group.
Okay, hello again. That was fabulous. I think I'm going to look over this video over and over again because it had so much content. And we had so many questions, and I appreciate you taking some of them because it's just great. So thank you for starters. One question I have is because of Midi being limited in terms of women over 65 being able to have Medicare participate with it, is there an out-of-pocket option?
We're working on it.
Okay.
And I got your letter today, Shelley, and I shared it. But
Thank you. I knew that ahead of time, and so I'm trying to advocate for us. Anyway, thank you for that. And then let me ask some of the questions that have come in that I appreciate. In 15 years post-menopause, what tests besides, and I love that last one you mentioned, the CAT scan of the arteries, but what other tests might you take to identify your risk?
okay. Well, so when we think about risk with hormone therapy, we think about breast cancer risk. So, you know, are you up to date on your mammogram? Have you had any high-risk breast lesions? Family history of breast cancer increases an individual's risk of breast cancer. We have some good studies that show that hormone therapy does not increase that risk further. So some risks add up, like cardiovascular risks tend to add up. Got hypertension, add smoking, add cholesterol, it adds up. This one kind of overlaps. So a family history of breast cancer, hormone therapy doesn't increase your risk further. So we look at breast cancer risk. Then we look at cardiovascular risk. So, you know, we could just talk about cardiovascular risk, like blood pressure, cholesterol. People like to measure little a, lipoprotein little a. But I do think that the coronary artery CAT scan is really becoming widely recommended and available. Many insurances are covering it. I don't know if Medicare covers it, but when your insurance doesn't cover it, it costs about $125 or $150.
Oh.
And so other ways of looking at cardiovascular risk are indirect. We're trying to correlate, does your cholesterol mean your risk is higher? But we can actually look and see. So that's a good test. And then, is there any history of clotting? Any history of stroke? Any history of cerebrovascular disease? We do see a little bit of increase in gallstones in patients on hormone therapy. So if you've had a lot of trouble with that, that would be a consideration. But those are the things we look at.
Excellent. Someone who's on Forteo, for example, right now, they're wondering if they're assuming BMD increases to mild osteoporosis, could the HRT be used after taking Forteo?
Oh, after Forteo, I don't think that there's like clear evidence or a clear path for that right now. That's not standard in any way. In fact, there's, we're still up against a huge evidence gap with hormone therapy. Like, so little research has been done, and it's not recommended for osteoporosis. So, I mean, once you have had osteoporosis, even when your bone density gets better, you still have that diagnosis. So there may be endocrinologists who would recommend that, especially if you've already done the bisphosphonate or not tolerated it well, but it's not standard care.
Okay. And someone asked, is there any higher risk of dementia with taking HRT?
It's a really good question. I just saw a question pop up though that I really want to address. Someone asked if vaginal estrogen increases the risk of gallstones. Vaginal estrogen is safe for everyone. There's only, the only people who can't use it are people who are on an aromatase inhibitor for for breast cancer treatment. Otherwise, like if you're on it now, otherwise vaginal estrogen is good for everybody. Everyone should have some. Because it really, I mean, it's not just about keeping the vagina healthy, but it's keeping the whole urogenital tract healthy, preventing UTIs, preventing urinary incontinence. It's just such great stuff. It should be over the counter.
I think so too. I agree.
There's really no medical condition that's a contraindication except for that one. But I'm sorry, what were you asking?
Well, and especially when you said that as women age, there's no evidence that it contributes to any more of an issue as you age, unless you have some outstanding.
Degenerate syndrome of menopause just gets worse over time. Like hot flashes go away, right? Night sweats go away after a while, but that just keeps going.
Let me see. Thank you. Thank you. Why don't endocrinologists recommend hormone replacement therapy? Is that NIH for most postmenopausal women? Is that NIH study? Isn't anybody discussing the flaws in that
A
study?
lot of people are discussing it. I mean, well, I feel like they are because I kind of live in the Menoverse now, right? So we've got our Meno stars on like Instagram, on Oprah and everything. And some endocrinologists do, I mean, many do, but there's still a huge knowledge gap. There's still a huge level of discomfort. But I feel like people are catching up, but it's very variable.
Yeah,
Yeah.
frustrating for some of us. What does it mean when your total estrogen is high, like 430 to 450, and all the hormones, including estrogen and estradiol, are in a good range?
It depends on your age. So if you're still cycling, your estrogen can be different like every day of the month. And so those numbers are not, they're not terribly high if you're ovulating or if you have a follicle, but if you're postmenopausal, that's kind of high and it might be reasonable to see a doctor about them.
Okay.
Can I jump in?
That's how it's done. Like the saliva tests are not as reliable as a blood test.
It
And
was
there
a-
are things that can interfere with the test.
Oh, I thought that was always the opposite, that a saliva test would be more accurate than a blood test.
I think that they're a little bit more prone to just having a spurious result.
So that was a serum test, and I am 58, and I'm asking because my doctor has no concern of a high total estrogen, and I am concerned. So I'm trying to figure out how to care for this. Does Midi, if
you could see us, you could see an endocrinologist or a gynecologist might be more helpful.
my doctor is a gynecologist, I'm just shocked. I know she doesn't look at total estrogen. So my understanding, is this true that a total estrogen count, that would be estrogen dominance? and you're getting too much estrogen?
So people talk about estrogen dominance usually like before menopause, when, you've got estrogen and progesterone levels and they're fluctuating and not in balance. But postmenopausal, that's a high estrogen. So like estrogen, when people talk about estrogen dominance, they're usually talking about the balance of hormones premenopausal.
Does DIM work to balance the estrogen?
I'm not sure. That's kind of not my area.
Okay, thank you.
Sure.
One other Forteo question, or
Okay.
one other question similar to the Forteo question. When someone is using hormone replacement therapy and they've been in the past used bisphosphonates for a long time, would that still be appropriate?
Oh, so you're saying after bisphosphonates using hormone therapy?
Mhm.
I mean, you can use hormone therapy. I guess I don't know enough about the context, because you can use hormone therapy for menopausal symptoms forever. You can stay on hormone therapy for bone health indefinitely. We tend to not initiate hormone therapy as standalone treatment for significant osteoporosis,
Mhm.
but otherwise, I mean, you can use it. I'm not sure I really understand that context.
Well, I guess.
Usually they follow up Forteo with a bisphosphonate. So it's a little off label.
Mhm.
Or it's a little bit different.
Makes sense.
The proof is in the pudding in many ways. I mean, if you are following your bone density and it's good, then.
Okay. So you have said that it wouldn't matter whether or not you were premenopausal or postmenopausal, it would improve bone density no matter what. Is that something?
Can you ask that again?
It wouldn't matter whether or not you were pre or postmenopausal, the HRT or would help no matter what.
So, I mean, women
Bone
start to
density.
lose generally the women start to lose bone density around menopause. So it's those perimenopause and menopausal women that estrogen is most helpful for. I don't think it's helpful for women in their 20s or 30s to try to build bone mass or anything like that.
Oh, I didn't mean that. I meant menopausal versus postmenopausal is probably what
But
I.
you can start it. But we're not doing a lot of bone densities in women who are premenopausal, right? The recommendation is 65 because we're trying to detect osteoporosis, right? We're not trying to detect osteopenia with that screening strategy. But younger women with osteopenia who are just premenopausal, or you don't have to wait until you reach menopause to use hormone therapy. We treat perimenopausal patients all the time, and they do get a bone benefit.
Excellent. What kind of blood clots would be contraindicated? And then I have one more after that. And then thank you for taking so many questions.
So that's a really good question. So most guiding organizations say that if you have a history of any blood clot, that you shouldn't use hormone therapy. And there's not a lot of data on this. There's lots and lots of data that shows that oral estrogen is associated with clotting risk, but that transdermal is not. So hundreds of women, thousands of women, millions of women in observational studies, we see no increase in the risk of blood clots in the general population. But nobody wants to study women who had a blood clot. No one's willing to put them on estrogen and see. We're going to do a control group of people. We're going to do a randomized control of like people who've had a blood clot. We'll put half of them on estrogen and half of them not. Nobody's done that. Actually, there is one small study, a few hundred people, but that's a database study, not a randomized control trial. So nobody wants to do that trial. Probably never will. But because transdermal estrogen, we know that it doesn't increase clotting risk in the general population, we do feel that the evidence supports use of transdermal estrogen in some patients who really value the therapy and who have a low risk of reoccurrence. They had a clot after they had hysterectomy, right? They've been tested, they don't have any kind of clotting disorder, they're not going to be in the hospital again. So, that they could have another clot if they have another provoking incident, but we don't think that transdermal estrogen increases their risk. Somebody who's had multiple clots or has a thrombophilia, that's a different conversation.
Yeah. Wow. Thank you. That's a great answer. And one last question, someone wanted to know was, do you have any experience or knowledge regarding seed cycling? I'm
What-
not sure what that is, so whoever
Seed
asked it.
cycling?
Yeah.
I'm just gonna say no.
I don't know the answer to that. I mean, I don't know what that means either. Did someone ask?
Kelly, seed cycling is a way in which some nutritionists are helping with balancing hormones.
Okay. No, I don't have any experience with it. Sounds interesting.
Wow. Dr. Osiecki, thank you so much. This
Really
was
great
so
meeting with you
informative.
guys. Get you gals. Yeah.
Well, we do have both. I don't know if they're on tonight, but we do have
Right.
some men in here too. But I really appreciate it. And you're such a great resource. And frankly, I'm kind of thrilled that you're right in Massachusetts. So we're going to keep our fingers crossed about Midi and see if I know if they're in 50 states, maybe they'll
We
consider.
just need to, we need to expand our age demographic. I'm just gonna look, I'm looking at some questions. How do we get in touch with Midi? You can look at www.joinmidi, joinmidi.com. Will HRT improve bone density in postmenopausal women? Yes. Vaginal estrogen, is this a ring inserted vaginally every 3 months? It can be. Usually it can be. There are vaginal rings for vaginal estrogen. How to take vaginal estrogen. If it's a cream, usually it's 1/4 of an applicator, 1 gram, 2 or 3 times a week. If it's a tablet, it's also there's usually a run-in every day for 2 weeks or so, and then either the cream or the tablet 2 or 3 times a week.
Is it dangerous to take the estrogen without progesterone?
If you have a uterus, it can increase your risk of uterine cancer, and the risk is significant. It's not like a trivial, like theoretical, like we really saw that. So we always, almost always prescribe a progestin for women who are on estrogen. Occasionally there'll be somebody who just, there's many ways to achieve that. There's many different progestogens, there are progesterone-eluting IUDs. So it's always recommended. All right.
I've
Okay.
heard that it's okay to take progesterone by mouth as
Yeah.
opposed to the estrogen. But I've also thought I've heard that progesterone is very different from progestin.
Right. So, progesterone is, people refer to it as bioidentical. So it's just a formulation of progesterone that's exactly the same as your body makes. And then the progestins, there are many of them. Usually where you see them is in oral contraceptives, but they're synthetic. There are 4 generations. So there's many different progestins that are synthetic, and those, for people who don't tolerate progesterone, those are an option.
Thank you.
I'm going to sign off. I think we could talk all night. It was a
I know,
really
right? I know. Thank you for continuing a little bit.
great. Good to see you, Shelley.